as in the last section when we looked at some integrated examples, we're going to look at the coordinated response of the respiratory system to hypoxemia and hypoxia, specifically what causes it and what we do to adapt to it. Hypoxemia refers to a decrease in the arterial PO2. It's got multiple causes. These are summarized in Table 5.5, and if you're following along in the text, this is page 230. High altitude, hypoventilation, diffusion defects, VQ defects, and right to left shunt. As we've discussed, a useful tool for comparing the causes of hypoxemia is to look at the AA gradient, or the AA difference. The alveolar to arterial gradient is the difference between the PO2 in the alveolar gas and the PO2 in the systemic arterial blood. As we talked about early in the chapter, the alveolar PO2 versus the arterial PO2. The alveolar PO2 we calculate using the alveolar gas equation. The AA gradient describes whether there has been an equilibration of oxygen between alveolar gas and pulmonary capillary blood, which eventually is going to go on to become systemic arterial blood. High altitude is one potential cause of hypoxemia. High altitude causes hypoxemia simply because the barometric pressure is decreased, decreasing the PO2 of inspired air, which decreases the PO2 of alveolar air. The equilibration of oxygen across the alveolar pulmonary capillary barrier should be normal. And the systemic arterial blood should be the same lower PO2 as alveolar air, and there should not be an AA gradient. We can help at high altitude by breathing supplemental oxygen, raising our FiO2, which is going to raise our arterial PO2. Hypoventilation is another possible cause of hypoxemia. Hypoventilation causes hypoxemia by decreasing the alveolar O2. There's less fresh inspired air being brought into the alveoli. Once again, the equilibration of oxygen should be normal, so systemic arterial blood should achieve the same lower PO2 as the alveolar air. Because the alveolar and arterial O2s are nearly equal, the AA gradient is normal. When we're hypoventilating, if we breathe supplemental oxygen, it's going to raise the arterial O2 by raising the alveolar O2. Diffusion defects are another possible cause of hypoxemia. This occurs by increasing the diffusion distance or by decreasing our total surface area for diffusion. In truth, I think clinically diffusion defects are not as important because they never occur in and of themselves. In other words, they always occur with either VQ mismatch or with shunt that we'll discuss in the next two examples. The equilibration of oxygen is impaired, however, and the arterial O2 is going to be less than our alveolar O2, so we have an increased or widened AA gradient. With a diffusion defect, if we breathe supplemental oxygen, it's going to raise the arterial PO2. It's going to do this by raising alveolar PO2 and increasing the driving force for oxygen diffusion. VQ defects always cause hypoxemia and an increased AA gradient. They're probably the most common cause of hypoxemia. Remember that a VQ defect is usually present as a constellation of abnormalities that may include regions of dead space, high VQ, low VQ, and shunt. Recall also that high VQ regions have a high PO2 and low VQ regions have a low PO2, but the high VQ regions can't compensate for the low VQ regions because of the curvilinear shape of the oxygen-hemoglobin dissociation curve. Let's go further with this. In VQ defects, why don't regions of high VQ compensate for regions of low VQ so that the PO2 evens out and becomes normal? The answer to this is that high VQ regions have a high PO2, but the blood flow to these regions is relatively low, i.e. high VQ ratio, and they contribute little to the total blood flow. In low VQ regions, where PO2 is low, they have the highest blood flow and the greatest overall effect on the O2 of arterial blood leaving the lungs. In a VQ defect, supplemental oxygen also is going to be helpful, primarily because it raises the PO2 in the low VQ regions where blood flow is highest. Right to left shunt is our final cause of hypoxemia. This could be a right to left cardiac shunt or an intrapulmonary shunt, as in the case of lobar pneumonia. They always cause hypoxemia and they always cause an increased AA gradient. The shunted blood completely bypasses ventilated alveoli and can never be oxygenated. And this shunted blood mixes with and dilutes the normally oxygenated blood. So the PO2 of the blood leaving the lungs must be lower than normal. Here's where shunt is different. The supplemental oxygen has a limited effect on increasing the PO2 of systemic arterial blood because it can only raise the PO2 of the normal non-shunted blood. The shunted blood continues to have its dilutional effect. Let's take this a step further. Hypoxia is decreased oxygen delivery to the tissue. Since oxygen delivery is the product of cardiac output and the oxygen content of the blood, hypoxia is caused by either a decreased cardiac output or a decreased oxygen content of the blood. Remember that the oxygen content of the blood is determined primarily by the amount of oxyhemoglobin. The causes of hypoxia are summarized in Table 5.6. Obviously, hypoxemia, low oxygen in the blood, will produce hypoxia. Table 5.6, which is on the bottom of page 231, describes different causes of hypoxia. As we mentioned, hypoxemia, all the things that we discussed previously, are going to cause hypoxia by decreasing the arterial O2. If we have a low cardiac output, it's going to decrease blood flow. That will decrease oxygen delivery to the tissue, regardless of what the arterial O2 is, and could produce hypoxia. Anemia will decrease our oxygen carrying capacity in the blood and decrease the oxygen delivery to peripheral cells. And we're going to talk about the special cases of carbon monoxide poisoning or cyanide poisoning. A decrease in cardiac output and decrease in regional blood flow are obvious causes of hypoxia. As well, hypoxemia, due to the causes that we discussed earlier in this section, can also cause hypoxia. The main reason that hypoxemia causes hypoxia is that the decreased arterial O2 reduces the percent saturation of hemoglobin, as shown in Figure 520 earlier in the chapter. Remember, oxyhemoglobin is the major form of oxygen in the blood. So if we decrease the amount of oxyhemoglobin, that's going to mean a decrease in the total oxygen content of the arterial blood. We could also do this with anemia. If we have less hemoglobin molecules, we're going to decrease the total amount of oxyhemoglobin in the blood. Now let's take the example of carbon monoxide poisoning. Carbon monoxide poisoning is going to cause hypoxia because, remember, carbon monoxide occupies binding sites on hemoglobin that normally would be taken up by oxygen. So, the carbon monoxide decreases the oxygen content of the blood. Cyanide poisoning also is going to interfere with this. Cyanide poisoning interferes with oxygen utilization by the peripheral tissues. In cyanide poisoning, we have hypoxia that does not involve either decreased blood flow or decreased oxygen content in the blood, but rather the ability for the peripheral tissues to use the oxygen once it gets there. That concludes our discussion of the distinctions between hypoxia and hypoxemia.